The following podcast is part of a certified educational activity titled Addressing Unmet Patient Needs in Bullous Pemphigoid, Exploring Targeted Treatment for Safe and Effective Care. Access the entire activity and complete the post-test at peerview.com/MPM860. Downloadable slides and practice aids are also available.
Hello, this is David Roseman from the Indiana University School of Medicine. Welcome to this educational activity on addressing unmet patient needs in Bullous Pemphigoid. Joining me in this discussion is Dr. Erin Barrett from the University of Nebraska Medical Center.
Thank you. I'm so glad to be here.
Today's presentation is on Bullous Pemphigoid. Our goals for today include to identify and differentiate Bullous Pemphigoid from other skin conditions that can present similarly based on current guidelines and expert recommendations, to discuss the impact of Bullous Pemphigoid on elderly patients with regard to morbidity, mortality, and quality of life, particularly for those with several comorbidities, to select and monitor treatment for patients with Bullous Pemphigoid according to updated guidelines, and to explain the rationale to improve outcomes for patients with BP through the use of targeted therapy. Today, we're going to be talking about Bullous Pemphigoid. This is the most common autoimmune subepidermal blistering disease of the skin. It's primarily a disease of the elderly with onset after 60 years of age. It's rare to occur in children. There are certain HLA alleles that are more prevalent in BP patients than in the general population. The incidence annually is around 6 to 7 per million, and it rapidly increases after the age of 60. The risk is about 300-fold higher for patients 90 years of age or older than in those younger than 60 years. Also, there's a slightly higher predominance in men than women. Interestingly, the incidence has been increasing over the past couple decades. As we are an aging population in the United States and on more medications, we're witnessing this increase in BP prevalence. It's becoming more important to recognize the disease and to treat appropriately. Also of note, there doesn't seem to be any geographical predilection for the disease.
As you can see on this slide, classic Bullous Pemphigoid typically begins with severe itching, followed by urticaria or hives, then blistering, characterized by these tense blisters on a erythematous or red base. However, as you can see on the next slide, there are many variants of Bullous Pemphigoid, which I will briefly touch upon here and in later slides. Approximately 20% or 1 out of 5 Bullous Pemphigoid patients will present with non-bullous forms, as shown in this photo on the right. About 10% of these patients will proceed to develop blisters later in their course. As many patients will either initially or persist in a non-bullous form, they often can be misdiagnosed as having eczema or atopic dermatitis, severe systemic allergic reactions, or urticaria, also known as hives. Thus, BP should be considered in the elderly when there's severe itching or unexplained rash. And then you can see on this slide, as I mentioned earlier, BP can have many different forms. It can be generalized, as shown here in some of the patients, or localized. Generalized BP can also present in different presentations. They can be bullous on the top left there, urticarial in the mid-top slide there, vesicular in the third slide on the right there, or papular. And BP can also appear in only the sites of trauma or friction, such as hands and feet, also known as dyshydrosiform Bullous Pemphigoid. It can also appear in sites of prior surgery, radiation, fistula, or ostomies. And I've shown one patient here, as you can see the radiation tattoo and the BP affecting the radiation site.
So what are the risk factors for Bullous Pemphigoid? Well, one of the biggest risk factors is age. The risk is about 300-fold higher when patients are 90 years of age or older compared to those who are younger than 60 years. And again, there's a slightly higher predominance in men than women. Second, there are genetic factors. For example, certain HLA types can increase the risk. Third, and incredibly important, are medications. Blood pressure meds, diabetes medications, and increasingly immune checkpoint inhibitors. As our lifespan increases and we have more elderly increasing in prevalence, additionally, there's more polypharmacy. So as elderly patients are on more medications, there's more opportunities for Bullous Pemphigoid to be triggered. In terms of the drugs associated with Bullous Pemphigoid, there are some associations that are stronger than others, and much of the evidence is from case series, but some of them include some diabetes medications, such as dipeptidopeptidase 4 inhibitors or gliptins, some diuretics, antipsychotics, And again, a really important class of medications that's causing increasing bullous pemphigoid are cancer immunotherapies. The PD-1 and PD-L1 in checkpoint inhibitors are becoming increasingly important medications in our therapeutic arsenal against cancers. And we're therefore seeing an increased number of cases of bullous pemphigoid because of that.
Bullous pemphigoid have been reported to be associated with a number of different conditions. The most important are neurological conditions, given there is a epitope of BP180 in the central nervous system that's suspected to cause this association. So many patients with BP also suffer from dementia, Parkinson's, many which had had strokes. So cardiovascular disease has also been associated, including hypertension, stroke, and various clotting disorders such as venous thrombosis or pulmonary embolism. In terms of autoimmune disease, there are some case series that reports that there's an association with psoriasis. The association with cancer is very controversial given that these are elderly patients. Some studies have found that there is an increased risk for various malignancies, while others have not shown this when adjusted for age. So the jury's still out. So when these patients present and have multiple comorbidities, the 1-year mortality rate is close to 23%, which is almost a quarter, so quite high. And as you can see here, there's many studies showing that BP also is associated with decreased quality of life and increased anxiety and depression as well.
The diagnosis of bullous pemphigoid is often with clinical suspicion. You have an elderly patient with tense bulla, it's very straightforward to test for bullous pemphigoid. But there may be other suspicious cases where you want to confirm the diagnosis, you're not sure, there's a differential, and biopsy is the gold standard for diagnosis. It's helpful to have both lesional for H&E staining as well as perilesional for direct immunofluorescence. On a lesional H&E stain, you would see a subepidermal bulla with lots of eosinophils, whereas on a perilesional direct immunofluorescence, you'll see linear deposits of IgG and/or complement C3 along the basement membrane. The pathologist may do salt split skin, in which the autoantibodies would be found on the roof or potentially both on the epidermal and dermal sides of the salt split skin. In terms of where to do the biopsy, for H&E, it's important to get a third of the peripheral portion of the blister, but also about 2/3 of the perilesional skin. And for DIF, when we say perilesional, it's about 1 centimeter away from the recent lesion. Now, oftentimes in dermatology, we think about using punch biopsies for inflammatory disorders. However, if you directly do a punch biopsy on a blister, sometimes it can shear off the blister. So there are some that will do shape biopsies instead to try to preserve the blister. In terms of ELISA or indirect immunofluorescence, those can also be useful to supplement the H&E and DIF. In terms of indirect immunofluorescence, that can be done with monkey esophagus or salt split normal human skin. And it usually is positive in 60 to 80% of patients that will exhibit circulating IgG antibodies, less frequently to IgA or IgE. And the ELISA will have similar sensitivity. Of note, the specificity of the ELISA is not perfect. In one study, up to 7.4% of non-bullous pemphigoid patients will have circulating BP180 or BP230 antibodies by ELISA that are non-pathogenic. So, Dr. Barrett, when do you suspect bullous pemphigoid?
I typically suspect bullous pemphigoid when there's an elderly patient with unexplained itch, and occasionally they can have intermittent rash as well, with or without blisters. However, I also always suspect it when there is any blistering rash. And so it's really important when you see these patients to not only do a standard H&E, but also do a DIF as well, because that's really the gold standard, like you mentioned on the last slide. I think for me, localized bullous pemphigoid is the most challenging and the easiest to miss.
Yeah, that's interesting. I find that sometimes the clinical presentations where patients don't have blisters can also be sometimes challenging. It's always really important to have it in your differential. Also, sometimes non-elderly patients for me can be challenging as well, because I often think of it as so much more prevalent in that population. And then also sometimes if there's ever mucosal involvement, also because that's so atypical. Are there any other clinical presentations that you find particularly challenging to diagnose bullous pemphigoid in?
No, I think those are really, really good points. Anytime I see someone middle age, I do have a couple of those patients. Itching is very, very hard to pinpoint or even know where to biopsy. But, the biggest challenge I have is when it's on existing inflammatory tissue. I remember a couple of years ago, I had a patient who only had blisters where she had stasis. And it was just really hard to pinpoint to distinguish what was the stasis and which part was the bullous pemphigoid. So I think I find those patients a little more challenging, but you're exactly right. Not every patient is going to present classically as the elderly patient with the itchy blistering rash.
What do you find is the most impactful for the patients? What is bothering them the most affecting their quality of life?
Well, I think, the itch of bullous pemphigoid has been described by many of my patients as mind-numbing. It is very, very debilitating. It affects all aspects of their life, including sleep to their ADLs. Luckily, the treatments we have in our arsenal, including systemic steroids and topical steroids, can help their itch very quickly. And the newer agents, which we'll mention later, that target the Th2 pathway can also be very, very effective in helping them relieving the itch symptoms even before the rash fully resolves.
Agreed that blisters can be quite concerning for patients, but the itch is what I find drives them the most to be miserable. And so you always have to ask your patients, how's your itch doing? Which I'm sure we both do.
Absolutely.
So in terms of our treatment goals for bullous pemphigoid, I like to say we treat patients, not disease. So very important that we improve our quality of life of our patients. And we want happy patients, not just necessarily that it looks better for us. In an ideal world, they would be medication-free and in remission. But even if that's not possible, if we can give them chronic management to make their lives better, that's oftentimes the goal and the state that results in the best outcome. When I think about treatments for bullous pemphigoid, I often divide them into different categories. For example, first, and oftentimes our first-line treatments are topical corticosteroids. And these can be highly effective, even though we think about bullous pemphigoid often as a systemic disease, and it can be quite impressive. Nevertheless, topicals can have a role. Second, we have our antibiotics. And even though bullous pemphigoid is not a microbial disease, it's not a bacterial one, the antibiotics can have anti-inflammatory properties, including doxycycline or tetracycline class antibiotics, which have, again, anti-inflammatory properties. They can help with matrix metalloproteinases. We also may use dapsone, which can inhibit neutrophils. We have our immunosuppressive agents that we traditionally use, including methotrexate, mycophenolate, azathioprine, and also some more targeted treatments like the anti-CD20 antibody rituximab. Also, which can be of great use, is IVIG, which can have a very favorable safety profile. Unfortunately, it's quite expensive and can be in short supply, but that can be a very meaningful agent for patients who are suffering. And then lastly, we'll have a discussion on these targeted treatments, including the anti-IgE omalizumab and the anti-IL-4 receptor antibody dupilumab.
Another way I personally like to think about treatment is in terms of two things. One is the therapeutic target. So in terms of whether we're targeting the inflammatory system, or are we targeting the adaptive immune system, or are we targeting the Th2 or I like to think of as allergic pathway. The other factor I think about is disease severity. So in terms of whether they have mild to moderate disease, localized disease, in terms of how high their anti-BP 180 and 230 titers are and where the disease is localized. And I'll go over some of these consideration on the next few slides, as well as evidence for treatment. So this is a table from a publication that broke down the treatment in a different way. So this is another way of looking at a typical therapeutic ladder. This slide shows that in localized or mild disease, you can think about using topical steroids or low-dose systemic steroids, plus or minus anti-inflammatory, antimicrobial, such as doxycycline or dapsone, as mentioned earlier by Dr. Rosemarin. And in more severe and generalized disease, in addition to using topical steroids to the entire affected areas, you may also consider using higher doses of systemic steroids as well as systemic agents, which will be described in the same table on the next slide. So as you can see here on the next slide, in addition to systemic steroids, you want to consider conventional immunosuppressive agents such as methotrexate, azathioprine, mycophenolate, and I would like to add to the list rituximab as well. And in patients, as shown here, who cannot tolerate immunosuppression or have incomplete response to immunosuppression, you want to consider adding doxycycline, dapsone, omalizumab, or dupilumab. And I want to highlight the next couple slides, evidence for various agents described here. First, this is an important study published in the New England Journal that basically compares topical steroids versus systemic steroid for bullous pemphigoid. So as you can see here, remarkably, topical steroids, when used to the entire body, actually perform better in terms of efficacy, 1-year survival, and severe complications. So when considering treatment for this population, do not forget, to try topical steroids first. So, however, there are some obvious drawbacks as shown here on the next slide, such as local side effects of topical steroids. There's also going to be difficulty with adherence, especially in the elderly and those with impaired mobility. And there is also consideration when used on large BSA, there's going to be systemic absorption and the same side effects that we see for systemic steroids. Another important study I want to point out is this randomized controlled trial from the UK and Germany. They basically was evaluating the efficacy of an anti-inflammatory, antimicrobial doxycycline in its comparison to systemic steroids. What they found was that doxycycline plus topical steroids, when compared to systemic steroids, that it was non-inferior. So I think the key takeaway here is that at least 75% or most of the patients do actually get better on doxycycline and topicals. The study also found that it is safer than systemic steroids. What about dapsone? Unfortunately, there's currently no randomized controlled trial, but case series does show that it can be effective in up to 80%. So rituximab, which is a drug that we use quite frequently in all autoimmune blistering diseases, the main evidence we have for bullous pemphigoid is not as strong as for pemphigus. It is from a small retrospective study, not a randomized controlled trial. However, the efficacy is found to be quite similar to some of the other autoimmune blistering diseases. As you can see here, this study in particular and multiple other studies found that it is over 90% effective. However, shown here in the next slide, the caveat here is that unlike for other autoimmune blistering diseases such as pemphigus, close to 40% of patients with bullous pemphigoid will require more than one cycle of rituximab to achieve complete remission. So always keep that in mind that if you don't get complete remission after one cycle, you should consider one additional. So when discussing this with patients, you should set expectation on how long the treatment will be. What about IVIG as mentioned earlier? So there is one RCT comparing IVIG to a placebo that favored IVIG in terms of disease activity score, but unfortunately it just missed statistical significance. And I reserve typically in my own clinic IVIG for patients who cannot tolerate immunosuppression or have underlying immune deficiencies or iatrogenic immune deficiencies. It is also a good adjunct treatment for those who need rapid disease control, but as mentioned earlier by Dr. Rosemary, it's very expensive. So in terms of assessing treatment response, it's almost identical to the initial assessment for these patients, which include a detailed exam of the skin and mucosa for activity of disease. We also assess for treatment-related side effects during the visit, so inquire about any infections, any other side effect they may experience. And then I also always check vitals on these patients. So that includes blood pressure and heart rate, as well as temperature. And depending on the medication they're on, you want to also check routine blood work for their liver function, creatinine, and complete blood count, as well as occasionally you can check a hemoglobin A1C if they're on chronic steroids. In terms of optimal duration of treatment, it really depends on the specific agent and the patient. In general, for immunosuppressive treatment, when used, I stop the treatment or consider tapering the treatment when the patient is in medication-induced remission. And that means that they have formed no new lesions in the last 2 weeks and all the old lesions are starting to heal. When considering stopping immunomodulatory treatments such as dupilumab, at minimum, they have to have no flare of disease for 3 months, but that's a bare minimum. And for many of these patients, given the really favorable safety profile, the treatments continued indefinitely for maintenance.
That was truly an excellent review of the traditional treatments of bullous pemphigoid. One aspect that I worry about is polypharmacy, because many of our elderly patients are already on many other treatments. I certainly use a drug interaction checker if I see a whole long list that's a page or 2 pages long. I wonder, do you have any tips or tricks that you can express, Dr. Barrett?
Yes. So I, like you, are a big fan of drug interaction checkers. I always like to double check everything. The MR we use has a really good built-in medication checker as well. But that obviously depends on how good of a history that you took and if you included all their medications. Luckily, most of the treatment that I just described in the last 10 slides do not actually interact with many medications such as antihypertensive or diabetes medications. However, one interaction that comes up a lot is when these patients are placed on PCP prophylaxis due to the bone marrow suppression risk. So I tend to prefer atovaquone if I can get it covered. But yeah, I think in general, you want to also consider the sedating factor of your medication. So many of these patients are elderly. So when you are placing them on anything like antihistamines for itch, you really want to make sure they're not on anything else for sleep. So those are the big ones for me.
Yeah, I think that's a great point with trying to avoid sedating side effects from the medications we're using to treat. And it's very different from how we may treat people who are itchy, who are younger, who don't have these comorbidities. You have to be careful. You also commented on prednisone and corticosteroid tapers. I'm always loath to give oral steroids or systemic steroids in general for any patients because of the systemic side effects. But one aspect is I have to be very careful about is too short of a taper, as you mentioned. Patients will flare if you taper off too quickly. You mentioned using prophylaxis for PCP. Do you take any precautions for osteopenia or osteoporosis in your patients?
That's a really, really good point. So I generally always put them on calcium, vitamin D, or if they have GI side effects from their systemic steroids, I'll put them on Tums. So it's like two birds with one stone. Just want to make sure they don't take it concurrently with some of their other medications that can be taken with minerals. But, I think most primary care physicians will help with this. If I think a patient is going to be on systemic steroids long term, I certainly would discuss with the primary care about a bisphosphonate for these patients. However, I think to minimize their risk, the most important thing to do is to start your steroid sparing agent as soon as possible. So I try to start that within 2 weeks of meeting these patients. That way you can minimize how long they are on systemic steroids. Generally, I try to keep my course less than 6 to 8 weeks when possible. But that's a really good point about bone protection for these patients.
And another question that always comes up is, well, how long do you give a patient on a certain treatment to see if it works?
No, that's a great question. So many of these agents are slow to act. So I divide them into kind of like short acting, medium acting, and longer acting. So in general, systemic steroids, IVIG, and some of the newer agents like dupilumab works relatively quickly for at least the itch and their symptoms. So those agents I usually give for around 4 to 6 weeks. And if they have no efficacy, then I consider increasing the dose or changing depending on the medication. For some of the immunosuppressive agents, those may take a little bit longer, and that includes methotrexate, mycophenolate. Those take up to 6 to 8 weeks to work, so you want to really account for that. And then rituximab is probably the slowest agent. It can take up to 12 weeks for it to work, but generally you should start to see improvement within about 6 weeks. So, when I start treatment, if I know a patient has bad disease and I'm going to start multiple agents, I really try to make sure that I start the longer acting agents early, because those are the agents that are going to get me off of the steroids, right? That are going to get the patients off the steroids. So I try to start them as soon as possible. Once you start the steroids, you should be thinking about the exit plan, right? You should be thinking about, and I'm sure you do the same, which medium agents to add and what long-term agents to add. But that's a really good point.
So bullous pemphigoid is fundamentally an autoimmune disease. There are both humoral and cellular responses against the two self-antigens, BP180 and BP230, bullous pemphigoid antigen 2 and BP antigen 1, respectively. Those antigens make up the hemidesmosome, which is an adhesion complex that promotes the epithelial to stromal adhesion. Also, Th2 cytokines are a key part of the disease. They are elevated in lesional tissue and patient's blood. Additionally, interleukin 4 is needed for class switching from IgG1 to the pathogenic IgG4 antibodies. A great study by Gil Josipovic showed that IL-13 levels also heavily correlate with patients' itch of bullous pemphigoid. So while we usually think of our Th2 diseases of atopic dermatitis, asthma, allergic rhinitis, we're now expanding what we view as type 2 inflammation. For example, eosinophilic esophagitis, maybe fibrosis, and now bullous pemphigoid. Autoreactive T cell responses to these antigens are crucial for stimulating the B cells to produce these pathogenic autoantibodies. After the autoantibodies bind to the BP antigens, there is a subsequent cascade, including complement activation, recruitment of inflammatory cells such as neutrophils and eosinophils. Also, proteinases are activated, which degrade the extracellular matrix proteins. Now let's take a look at this brief 3D animated video clip that will help illustrate the role of type 2 inflammation in bullous pemphigoid.
Bullous pemphigoid, or BP, is an autoimmune subepidermal blistering disease that mainly occurs in the elderly, severely affecting their health and quality of life. Patients with BP usually develop pruritic, tense blisters locally or widespread on normal skin or erythematous background on the trunk and limbs. BP180 and BP230 are two types of hemidesmosomal proteins that are located in the basement membrane zone and responsible for the dermo-epidermal junction. In patients with BP, BP180 and BP230 are recognized and processed by antigen-presenting cells, which in turn stimulates the type 2 inflammatory process, differentiating autoreactive Th2 cells and secreting cytokines, including IL-4, IL-5, and IL-13, and prompting the class switching of B cells. The class switching of B cells leads to the production of autoantibodies, IgG and IgE, resulting in their deposition in both the peripheral blood and the local basement membrane zone, and binding to BP180 and BP230, although the autoantibodies to BP180 appear to be more common than the autoantibodies to BP230. This begins the process of complement activation, mast cell degranulation, neutrophil and eosinophil infiltration, and degradation of BP180. In addition, the binding of the autoantibodies to BP180 and the subsequent inflammatory process destroys the hemidesmosomes and causes the formation of subepidermal blisters. Eosinophils contribute to the pathogenesis of BP in several ways, by contributing to dermal-epidermal separation, by producing Th2 cytokines, amplifying and sustaining a local immune response, and by releasing IL-13 and IL-31 and playing a role in pruritus. A variety of studies have revealed that the levels of IL-4, IL-5, IL-6, IL-10, and IL-13 are elevated in the serum, blister fluid, and skin biopsies of patients with BP. Among them, IL-4 is considered to have the closest association with BP because it is particularly essential for Th2 cell differentiation, class switching of B cells, and production of IgE. IL-13 is another crucial cytokine in BP and has some common features with IL-4. Owing to their significance in BP, several targeted biologic agents already approved for other type 2 inflammatory disorders are under study for treatment of BP, including dupilumab, which binds to the IL-4 receptor alpha subunit and inhibits IL-4 and IL-13 signaling.
As shown here, as you know, omalizumab is a monoclonal anti-IgE antibody that's currently approved for asthma and chronic urticaria. And as you are all aware, it has been used for bullous pemphigoid. This is an image from the original case series in which they used it in 6 patients with both urticarial and blistering presentations. And they had a quite impressive response rate, about 83%. And remarkably, 50% of patients responded to it as a monotherapy. However, the caveat here is all the patients showing this case series had an elevated total IgE, and most had eosinophilia as well. And as you know, that total IgE has been found elevated in up to 70% of patients with BP. However, in my clinical experience, not all patients will have this. So up to 70% will have elevated IgE. So about 30% do not. And I find that omalizumab works best in those patients who fit that profile with an elevated IgE, given that it's the target of this medication.
So we spoke about the importance of the type 2 inflammatory pathway and the cellular and humoral immunity as part of the pathogenesis of bullous pemphigoid. Because of this, dupilumab has been used in bullous pemphigoid. This was the first patient that was treated with this medication. He was an 80-year-old male with latent tuberculosis, Hep B core positivity, and quite frankly, couldn't get off of prednisone. Every time we tried to taper, the patient was rehospitalized. So we tried dupilumab, and insurance companies, I think, realized it was cheaper to try this option than having the patient get rehospitalized. And he had quite a remarkable response. His itch improved in 1 week. His blisters completely resolved while on treatment. And I'll say that 7 years later, he continues to be blister-free since starting. So you can see in the picture, he had quite severe disease before treatment. And then on the right, he became blister-free shortly after starting. You can also still observe the post-inflammatory hyperpigmentation that we can sometimes see in skin of color patients as they improve. Now that we have more experience with dupilumab, there is a recent study published in JAMA Derm about a cohort experience. Here, there was 146 patients with bullous pemphigoid, and 87% of those were treated with dupilumab at the standard atopic dermatitis dosing of 300 milligrams every 2 weeks after an initial loading dose of 600 milligrams, and achieving control within 4 weeks. So of those, 35.6% are achieving complete remission, and only 9% are relapsing during observation. There was a rapid and sustained improvement in this BP dye scores, which measure our bullous pemphigoid measure, in the itching scores, in the autoantibodies that were detected, in total IgE levels, and eosinophil count. So dupilumab really seems to target directly the pathogenesis of bullous pemphigoid. In terms of the safety of the medicine, no new side effects were popping up in this population. It seems to have similar adverse events to our use in other diseases, which are infectious, and you can also get a transient eosinophilia as well. Of note, they found that higher autoantibody levels, like anti-BP180 antibody levels, were associated with better control. Also, they did see a slight association that male patients were more likely to relapse, although we'll have to see if that bears out in future studies. There currently is a phase 3 pivotal study that is underway. The design is a 1-to-1 randomization of patients to dupilumab or placebo. All patients are getting some prednisone to start, which is then tapered down. And the endpoint is measuring patients who are blister-free. And it will also hopefully show that patients have a reduction in itch when they're on dupilumab compared to placebo. Currently, dupilumab is used off-label. However, with this study, hopefully we'll get regulatory approval.
Complement inhibitors are also very interesting and being considered for bullous pemphigoid. So this came from basically an older drug, cromolyn, which stabilizes mast cells. It had been reported in some patients to improve their pruritus, given that complements and mast cells have a very close relationship. Mast cells can be activated by various complements, and it can also produce complement in itself. Several groups are looking at using complement inhibitors such as C5a, which is a mast cell activator, as well as leukotriene B4 inhibitors to improve symptoms of bullous pemphigoid. And a small phase 2 trial did show that there's improvement in 9 patients with bullous pemphigoid. So more to come on that. And as you know, BP is a disease that affects the elderly with many comorbidities. So the goal of treatment is really to find as targeted treatment as possible. So the future of the field is really moving towards therapies that target the Th2 pathway. So several of the ongoing trials are focused on anti-eosinophilic agents, including 2A agents that target the IL-4 and IL-5 pathway, both of which are potent eosinophil activators. Currently, anti-IL-5 is approved for asthma. Another target is taxin-1, which is eosinophil and eosinophil chemoattractant. So the gradient of taxin-1 recruits eosinophil into the skin. And currently, there's a phase 2 trial studying anti-taxin in bullous pemphigoid. pemphigoid. And one other agent to mention, efgartigimod, is a neonatal Fc receptor antagonist. It's currently being studied for both pemphigus vulgaris and bullous pemphigoid. This is not really a target for the Th2 pathway, but it is a newer drug I want to briefly mention here. So neonatal Fc receptors basically protect immunoglobulin IgG from degradation. So by blocking this receptor, the total antibody level quickly lowers. So this drug has a potential for rapid disease control in these patients, but it is considered an immunosuppressive agent still because it has the potential to cause hypogammaglobulinemia. So many new drugs coming down the pipeline, so stay tuned. So this slide shows the design of the current trial for the neonatal Fc receptor antagonist, efgartigimod, for bullous pemphigoid. As you can see here, the medication is given intramuscular weekly for 35 weeks with a concurrent prednisone taper. So more to come on this.
Now we're going to go over two different cases. The first one is a patient who was originally referred to me and managed jointly with Dr. Michael McLeod, a blistering disease expert at Tufts Medical Center. She was a 70-year-old with both bullous pemphigoid and psoriasis and was initially treated with oral steroids and then with methotrexate and IVIG. Unfortunately, she had a bad reaction to IVIG. She had compression fractures while on steroids, and the methotrexate alone did not control her disease. When she was initiated on dupilumab, she had a notable response, but not a complete response. She was subsequently increased to dupilumab weekly, so double the standard dose, and that cleared her. You can see in the pictures of her hand, she had significant involvement, and subsequently after starting on dupilumab, she completely cleared. Even though this is just a picture of an isolated part of her body in her hand, she really had blisters all over her body. Subsequently, unfortunately, she went off of dupilumab. It was discontinued by a non-dermatologist during a hospitalization for a gastric ulcer, and a month later, her disease recurred. Luckily, though, she restarted dupilumab and recaptured her original response.
Our second case is a man in his 60s with obesity and hypertension with acute onset of blistering rash. Biopsy was performed for H&E and DIF to be consistent with bullous pemphigoid. And ELISA was done as well, showing quite high titers for this patient. As you can see in the image here, he has classic bullous pemphigoid with positive DIF and really high autoimmune antibody level. The decision was made to use anti-B cell agents on him, given that he had a classic presentation and clearly had a really active adaptive immune system with the high anti-BP180. His treatment course included temporary taper, a brief taper of prednisone, concurrent use of mycophenolate as a steroid-sparing agent, and early rituximab. And this patient only required one cycle, and at the end of the 12-week period, so 3 months period, his skin was completely clear and everything was stopped. As you can see here on the next slide, at 1 year follow-up, he was still in remission, completely clear, and he remained clear at his 2-year follow-up and then did not return for subsequent follow-up, given that he remained in remission.
So, Dr. Barrett, I sometimes will use some targeted treatments for those who are particularly fearful of side effects from treatments or maybe the recalcitrance of some of our traditional therapies. When do you like to use some of the targeted therapies like omalizumab and dupilumab?
I think, when appropriate, when in patients who cannot tolerate immunosuppression, I prefer to go to dupilumab or omalizumab quite quickly. And your work really have pioneered this in the last couple of years. I've found that it's easier and easier to get dupilumab approved for these patients. However, it sometimes is still very difficult given that unless they have concurrent atopic dermatitis, it's still not approved. So hopefully with the new phase 3 trial, that approval will be in the future and we can use this on all of our patients. For patients with severe disease, such as shown in case 2, who have very high anti-BP180 titers, and when I cannot get dupilumab approved, I will do the anti-B cell agents, including rituximab and mycophenolate, given I know that they will be put into remission by that regimen. Omalizumab, I found, is a little more difficult to get covered than dupilumab currently, and I think with the phase 3 trial, dupilumab will become even easier to get covered. The one population I have not had issues getting both of these covered is the cancer population. So most of the time I can get dupilumab and omalizumab covered for those patients. I think that's a great point. Unfortunately, in our everyday practice, we are limited by what is covered for these patients and what is not. But in the ideal world, I think targeted therapy is preferred.
Absolutely. The medicines are only as good as their access. I also find that if a patient has a malignancy, you want to make sure you document that as the reason why you may want to give one of these targeted therapies. And oftentimes that facilitates approval. I have had some success getting dupilumab from Medicare patients, but not always. Do you have any tricks to getting the medication that you want approved?
A lot of these elderly patients have concurrent atopic. A lot of times, after I've treated them in those cases where I treated them with rituximab and mycophenolate, they still have residual itch. A lot of times it's difficult to distinguish whether it's from their baseline eczema or their bullous pemphigoid. In those cases, I usually document their xerosis and excoriations, and I prove that their titer is low. In those cases, I have been able to get the dupilumab covered for them. But it is very, very difficult. And like you said, I think documenting comorbidities that prevent them from being immunosuppressed is really important as well.
I agree with you. I think making sure you document those comorbidities is probably the most helpful step to trying to get approval for our patients. Do you ever increase the dupilumab dose?
Yes, so to answer your question, there's two ways to do it. So you've shown a really amazing case of weekly dosing. The other way to do it is to increase them to 600 biweekly. And I have one case of that in the last few years where I needed to do that if we can get it approved, but it's rare. And that was for a oncology patient as well. But I think it's rare that we need to increase. Typically the 600 loading and the 300 every other week manages their symptom quite nicely.
In terms of the patients who have developed bullous pemphigoid from a checkpoint inhibitor, do you do anything differently in terms of your management?
Yes, so that's a really, really good question. So you really want to stay away from long-term systemic steroids, given that it does decrease the efficacy of the checkpoint inhibitor. So the studies actually say you should stay below 7.5 milligram, which is quite low. And you really want to be as targeted as possible for these patients, right? So my preferred steroid-sparing agents would be, if you cannot get one of the targeted Th2 agents approved, then you would think about an anti-metabolite like methotrexate, and then even rituximab, a lot of oncologists are fine with, given it's more of a targeted biologic. But as we discussed earlier, right, you have a really good chance of getting dupilumab approved for these patients given their cancer diagnosis. So that's really preferred. Yeah.
We've discussed the epidemiology, the comorbidities, the varied clinical presentations, pathogenesis, traditional and emerging treatments today. In summary, bullous pemphigoid, it's increasing in incidence and can have some really non-traditional presentations, so it's very important to have on your differential diagnosis. We have multiple traditional options which can help different patients. They also have their challenges in terms of drug interactions and side effects. Luckily, there are some exciting new treatments on the horizon that will hopefully change the way we treat the disease. So thank you so much for joining us, and I hope you found this program to be useful as you care for your patients with bullous pemphigoid. I want to particularly thank our expert, Dr. Barrett, for being here and contributing her insights to the discussion. Thank you.
Thank you.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/MPM860. This activity is supported by an educational grant from Sanofi and Regeneron Pharmaceuticals.